Good afternoon, everyone. Thanks a lot for coming today to talk to all of us. My name is Asger Kjærum. I'm the Advocacy Director at the IRCT. I'm just going to talk about IRCT for a minute and a half, and then I'll hand over to my colleagues. So as I said, thanks a lot for coming. The IRCT is a global association of torture rehabilitation centers from 74 countries, 161 members in total. I'm very happy to see 3 of them here today, including 2 members from Denmark. We were born out of the crisis of dictatorships in Latin America, where a lot of torture victims fled to Denmark and arrived in the 70s. The Amnesty International Medical Group started to support the victims, and from there became what was first RCT and later split into Dignity and the IRCT. So this is really a very big part of our history, and I think it is something that is important to remember today, because that history is not only the history of the IRCT, but it's also the history of rehabilitation for torture victims in Denmark. I have grown up with very, very good friends whose parents went for treatment at RCT back in the 70s and 80s, and they still managed to live a seemingly normal life where their kids grew up and became architects and journalists and so on. So we really have a very rich experience here in Denmark and all around the world on how to do rehabilitation. At the same time, there are also a lot of things that are still missing. That's what we are going to be discussing here today. How do we get better identification of torture victims? How do we make sure that services are better culturally adapted? And so on. So for all of these reasons, I'm very, very proud to present what I think is an extremely interesting panel of experts who's going to be discussing with us for the next hour and a half. I'm very happy to see so many familiar and unfamiliar faces here, and really hope that you will engage in a discussion on how we can move this forward, how we can learn from each other, all to support life after torture. So thanks a lot for coming.
Thank you very much, Asger. Distinguished panel, ladies and gentlemen, welcome. I've been given the honor of moderating this session today. I'm very proud. Today we're going to talk under the title, My Mind is Not Like Before, which to me is a very strong way of saying that torture is something that influences people at a very deep level. One of my other quotes is someone saying, I don't feel like a person anymore. I'm not sure I am a person anymore. That's how deeply affected people may become by torture. But today we're not going to talk only about torture. We're also going to talk about the context that torture survivors experience, not only in their home countries, but also on their way to Europe during horrible conditions, when they flee whatever country they come from, when they cross the Mediterranean Ocean on Aquarius, or that we have heard about just the last few days. We also heard about minors committing suicide, that was mentioned in The Guardian, minor refugee children who can't cope with the situation that they end up in. People talk about a refugee crisis, and I sometimes ask myself, whose crisis is the refugee crisis? Is it my crisis? Is it our crisis? Is it the torture survivors' crisis? There's a lot of different ways of looking at the crisis, but unfortunately the term refugee crisis has gotten some political connotations, at least in Denmark. So when we talk about the refugee crisis in Denmark, sometimes we tend to think about all the huge numbers of refugees coming into our country and changing our country forever. Let's switch around a bit and let's see what conditions these people come from. Because to me, the refugee crisis is not 3,500 people coming to Denmark as asylum seekers last year. That's the number we're talking about. 3,500. To me, The refugee crisis is the crisis of people living under horrible conditions where they need to flee to save themselves, to save their own lives, to save their children, to save their wives, to save their families, and to survive in different contexts. I'll say just a few words about Denmark, and then I'll hand over the floor to Pau, who will continue. In Denmark, as I said, last year we received 3,500 refugee or asylum seekers. That's what we call a crisis. 2 years back, or in 2017, the number was higher. It was 21,000. And I'm sure that the political climate has done in Denmark what it could to make people not come here. When you look at the web page of Udlændinge- og Integrationsministeriet, the ministry responsible for this in Denmark, they have a counter. Have you seen it? They have a counter on the web page counting the number of new restrictions put on people who come to Denmark. They have now, within this government period, reached 89 and still counting. I think that's a very clear indication of the political climate. We have a lot of challenges in Denmark. We have now quite a low number of refugees or asylum seekers coming to our country, and nonetheless, we have all the same challenges that are experienced everywhere else. We have difficulties identifying people. We have difficulty understanding what they are telling us, either because we have lousy translation or because of contextual cultural reasons. We simply can't understand what's being said. We don't have validated screening tools to identify. We have, as long as people are asylum seekers, they only get the necessary treatment, the treatment that can't be postponed, whoever decides what that is. We don't do many medical legal reports for people who claim to have been tortured. And there's a lack of knowledge in the whole healthcare system after people get their refugee status. So they may run the risk of going from one health provider to the other, not actually receiving what they need. Luckily, we also have centers that provide treatment, but they have waiting times. They have a limited capacity and not always enough capacity in comparison to what is needed. So there's a lot of challenges that immigrants and refugees are facing in Denmark as well. We'll now hear about challenges in other countries. We'll hear about Spain, about Greece, about Germany, and finally about Denmark. And I won't say more for now, but hand over the floor to Pau Perez-Sales, who's from Spain, and the current editor-in-chief of Torture Journal. He will talk both about the timeline, the framework to understand what do we know and what don't we know, and we'll also talk about the conditions in Spain. Pau is a psychiatrist, a PhD, has more than 20 years working experience from Spain and also from Latin America. He works with is the director of the CIRA Center in Madrid and is linked with the Grupo de Acción Comunitaria and the Hospital La Paz. I'll hand over the floor to you, Pau.
Thank you. Well, initially I was going to summarize the editorial of this special section, special issue, but later we found more interesting to share about our work in Spain. You can read the editorial, it's there, but maybe you don't have the opportunity to have some information on Spain. So I will try to use the example of Spain and us, CIRA, as an organization, to show that, in fact, we just grasp a small part of the reality of all the migration process. And most of you, I assume, work in organizations that work with survivors of torture, with migrant people, and probably we are not always aware that we are just working with a very, very, very small part of all the suffering that the migration process entails. So these are the points that I will cover in the 10 minutes I have, and I will try to reflect on this idea of the migration continuum and the work of the organizations there. Okay, in Spain, most of the migrants come through airports, but those are not the ones we work with, because migrants that come through airports come from Latin America. At this moment, almost all of them come from Venezuela and from Colombia, and they are not given asylum when they have any possibility at all getting asylum, or they come from Europe, from Ukraine and other. This is the big part, but this is not the ones we work with. In my center and most of the centers, we work with African people, people that come from Africa through the south border. We are the south border of Europe, and we are supposed to defend Europe against those African people that try to get inside. So it's a minority, but it's a minority that suffers a lot. And this is a map of people that has death in the Mediterranean in the 6 months of 2018, and as you can see, about more than 200 people died in Spanish waters. From Africa to Spain, there is just 14 kilometers. You see Spain from Africa, so you have the temptation to, take any boat, anything, to try to cross, and the sea is very dangerous. The sea is very dangerous, and also there is a lot of control by the police, by the authorities, and it's not easy to cross. So, just to put you in context, today is Monday. From Friday to Sunday this week, yesterday, the day before yesterday, 89 boats tried to cross from Africa to Spain. 89 boats. 1,290 persons were rescued in 12 big boats and many small ones. These are the ones that were rescued. Many more probably succeed, and we don't know the figures. And we know about 4 dead persons and 43 disappeared persons, and 2 boats lost track. There are some organizations who are based in Morocco that try to keep track of the boats and try to advise when a boat is lost. Some of them are indicted and are pending of being judged, being accused of trafficking. And what they are doing is trying to keep track of the boats to help people. The Aquarius crisis, that boat that nobody wanted and finally goes to Spain, is just a makeover. It's, if you see, this is 600 persons. It's just 1/3 of what comes in one weekend. But, it's very mediatic. There were journalists in the ship, and it was, a kind of, trying to give a good image of the new government in Spain. But the problem is bigger. The number of boats that cross depends on the month of the year. Now it's supposed to be the best moment to cross. This is why there are so many ships crossing. Yeah. But the number of people that dies trying to cross is very high, but it's less than middle of the number of people that dies crossing the desert. And we don't know what happens there. We have an estimate through the voice of the survivors, the people that we receive in Spain, and in fact we know that many more people dies trying to cross from the country of origin to the border than in the process of crossing. But this is the dark side. This is the part, when I say that we are just grasping a small part of the reality, this is part of the reality that we don't know what is happening, that almost nobody is working there. We have part of the team here in Morocco, in Montebolingo. It's a mountain close to Nador. Nador is a town that is close to Melilla. Melilla is Spain, Nador is Morocco. There are about 5,000 persons living in shelters there, waiting for their opportunity to cross. And we are one of the very few organizations that is there in the shelters and trying to work with people and receiving their bodies. This is This is from the editorial. It's the only slide in which I... and tries to show which are the elements that have been part of a study in academic research related to torture and the migration process. And if you see, there is torture in the home country. You have a lot of research on that, and you have a lot of evidence that torture, of course, torture and persecution affects mental health and affects psychological well-being. That's obvious. We don't have almost research on torture during migration process. Some anthropological work, but not academic work. And then, we'll see later, we have a lot of literature on asylum claimants, on people that already arrived to our countries. But there is a big hole there. We don't have information. And we know that there is kidnapping, there is extortion, there is trafficking. We know that. We know that there is massive human rights violations. Probably in the African borders, we don't have information, but they work a lot in Mexico. And just in the Mexico-Guatemalan border, there have been 20,000 people disappeared in the last 3 years. Disappeared means disappeared. They are the modern disappeared people, you know, in the hands of drug dealers, in the hands of local police that sells people to trafficking networks and so on. So there are massive human rights violations. We have very, very few data on what's happening in this migration process. And you know, there is every time more people that says that we should ask as health professionals that all these people that suffer torture and ill treatment during migration process should be given at least a humanitarian status. In spite they don't have the criteria for being considered refugees, they should deserve some kind of protection because of that. So there is a migration continuum, and we just see when they arrive here. This is the fence in Melilla. As you can imagine, this is Spain, and this is Africa. Well, everything is Africa. It's a colony of Spain. But, you know, that's the fence where people try to jump, and this is consequences of trying to jump the fence. I put this picture because this is part of the work we do. This is a young boy that trying to jump. He was very bad injured because there are knives in the top of the fence. And this is a case we presented in the European Court of Human Rights because in spite of all his damage, he was sent back to Morocco without giving any opportunity to claim for asylum. So we went to Morocco, we found the guy, we documented the case, and did the Istanbul Protocol, and now it has been accepted in the European Court of Human Rights. That's a case of strategic litigation, which is one of the main works we do. The process in Spain, I think it's quite similar to other process in Europe. The person once entered, it's informed that he will be expelled, and most people, while waiting being expelled, disappear and tries to survive as undocumented migrant. This is also part of this, you know, reality that we don't grasp. Undocumented people that we don't attend in our centers. And then you have to go in a kind, you know, of chimera, which is trying to work and live hidden. Because if you manage to be for 3 years without being catched by the police, then you can get your documents, if you are able to show that you were there. But of course, you are not allowed to work, you are not allowed, yeah. Then the other option is claiming asylum, but very few people from Africa claim asylum because they are not informed, they don't know their rights. There's no legal information in the border, and the police, of course, doesn't say that you can ask for asylum. So most of people is from countries which are not candidates, not considered candidates for asylum. Then you have an initial interview. Now you have to make an appointment, and it takes about 4 months to be interviewed by the police. During these 4 months, again, you are homeless, you are undocumented, and nobody helps you. Any organization provides help because you are not an official asylum seeker, so you are left to your own fate. And 25% of people is rejected at this initial interview, no translator in a police station, you know, and of course, if you have been traumatized, then the interview is given, you know, in very bad condition. And some of the people goes to a second interview that can take months or even years, and if he has been or she has been accepted, and this is a hard interview, takes 3-4 hours. This is where we work. We work with people that has the red card, that has been admitted in the initial interview, and is waiting for the second interview, is being admitted to the process. So it's a very small selected group of privileged persons that knew that they could ask for asylum. They were able to overcome the initial interview, and finally they arrived to, wow, our nice organizations that will provide help and anything. And just 4% of this will get asylum, but quite more will get subsidiary protection. So they will be able to stay for humanitarian reasons. So the big majority of people remains undocumented in the country and will receive no help, no support at all. Finally, well, if you are of this small group of privileged that have the red card, you will have this small help for shelter, for basic support, and some economic assistance for 18 months. After that, you are left to your fate again. And you see, you see a huge number of people is finally deported. This is something, again, under-researched. We don't know what happens with people that has been deported. We have some reports that suggest that many people is detained when arriving to their countries, because simply asking asylum in a European country makes you suspicious of, you know, anything. So if you go back to Uganda, if you go to a country where then when you are deported, the police, the Spanish police, hands you to the Ugandan police or hands you to the Cameroon police, then you are immediately detained, and we have some reports that many people is tortured, many people is interrogated, and why he asked for asylum in Europe. Okay, then we have the other part. This is the part when we have a lot of information, people that ask for asylum claims, and we know, and Marie has said that we don't know how to do good screening. There are many screening tools, but none of them validated up to now. Some are based on clinical diagnosis, some of them on vulnerability factors. We have some research on the relationship between poverty, torture, and mental health, or access to health care. These are topics in which you can find a lot of literature, and we have a lot of literature on the mental health impact of being detained, of the detention process. That's something that there is strong evidence of the negative impact of being detained in any of the many detention centers we have in Europe. Also, on the delay in the procedure of decision, the anguish that this creates, or, for instance, on not being considered credible in your allegation. This is something we have information, and we know that all these are elements that are determining the mental health of survivors. And again, some people are rejected. Again, they go to this hidden majority of people that we don't know what happens with them, or are deported, which, you know, we don't know the risks at arrival. Yeah. Very briefly, our work, we are a network of young people. We are all volunteers. It's a big team, 2 psychiatrists, 6 psychologists, 2 doctors, 2 lawyers, and body therapists. And we all work just as volunteers because we think that working in human rights must be a personal option, and because we want to be independent from political powers. So each one devotes the time he can to the organization. What we do? We do psychotherapy for complex trauma, including cultural focus. We work with African traditional healers, and we try to make psychotherapy including cultural components. We do a lot of strategic litigation in the Inter-American Court, in the European Court, or in the Spanish universal jurisdiction cases. And we also part of the process against torturers from the Spanish dictatorship. And we do a lot of forensic reports for asylum claims. We do 5-6 reports every month for complex cases that other organizations send to us. And I must say that we have a lot of success, because very few people does Istanbul protocols in Spain, very few people. And this means that the cases that are well documented have more success than other cases. Okay, and well, the strategic litigation is a big part of our work, because we work in all the process of strategic litigation. We work with the survivor trying to defend the strategy. We work with the legal organization that presents the case, and we defend the process in court, and we do the follow-up of the survivor, and if the survivor needs psychotherapy, whatever, we also provide that. Yeah? We are litigating in Mexico and quite a few places. Well, we do a lot of training, and we try to supervise other organizations where they do Istanbul protocols. And finally, and I'm finishing here, we try to do some research, which is not easy because we don't have funds. We have a website in which we have designed some tools to assess torture, and we have one tool to assess the impact of trauma, another to assess torturing environments, and another to assess coercive interrogation, and this is in Spanish, in English, and French, and it's free for use for any person, any organization that wants to use. We are trying to work on a new website that provides free access, including the correction of questionnaires, to any one of you that want to use it. But, well, this goes slowly, because that's what happens when you're a volunteer, that this has a cost, and we go step by step. Okay. Well, that's what I wanted to present you. I led this slide that I think can be useful for other presenters also.
Thank you very much, Pau. There will be plenty of time for questions afterwards, so please make sure that you start thinking about good questions. If there's any quick questions now to Pau, we have time for one or two now. Otherwise, we'll proceed to the next presenter. Okay, think while you listen to the next presenter also, who is Christina Popontopoulou from Greece. Christina is a clinical psychologist, and she works with Médecins Sans Frontières, Doctors Without Borders, in Athens, and has been doing so for the last couple of years. She works with migrants and refugees who have suffered torture and ill treatment. And also she has been working with minors. And before working with these groups, she has worked for many years with rehabilitation of drug addicts, which is a completely different field, but I'm sure some of the experience can be transmitted to what we're going to talk about today. Please, Christina, the floor is yours.
First of all, I want to say that it's very nice for me to be here and to I just want to say that it's very nice for me to be here and to share my experience from Greece. What I really want to say today that that the trauma doesn't stop in the border, that the trauma is something very complex, and when somebody is working with so much traumatized people, it's very important to have in mind that there are a lot of factors that affect the mental health of victims of torture who are also refugees. Okay. It's better now? So I will try to describe the effect that everyday stressors, environmental, cultural, and the broader context has in mental health of refugees. And this is a part of a bigger research that is done in the clinic in Athens. And I will try to speak about this factor through 3 cases who used to be our beneficiaries. They used to accept services from the clinic in Athens. So the goal was to better understand what is trauma and how the people understand the trauma and the symptoms and how they conceptualize their symptoms. And the second goal of the research was to see how the rehabilitation of VOTs is affected by environmental factors. What is very, very clear, and this is one of the conclusions, let's say, from the research, is that in Greece, you can see 2 different stages, when somebody is asylum seeker and when somebody is already recognized. And these 2 stages are affect in different ways the mental health of the population. So, for me, it was very important to bring their speech, their words, because they are the people who we try to heal and the people from whom we are learning a lot of things. So the first case was the case of Dean, who is saying that I know only one thing, that my work is just only this room. I'm just killing my time, and you can read the rest. I learned a lot from this person, and I really want to share with you our first appointment. And this is very important because sometimes we don't think about the cultural issue and about the way that they perceive what is psychotherapy and what is the psychologist and what is psychological support. So the first time that I had the appointment with him, I asked him if what is the reason he asked to see a psychologist. And he shared that, I don't know, I came because my social worker told me to come, my lawyer told me to come, a police officer that I meet in the road told me that I need a psychologist, and also my roommate insists that I need a psychologist. And when I asked him, why you believe that all these people recommend you to come to see the psychologist, he said, I don't know, maybe they need psychologists. The only thing that I need is a home, and the only thing that I need is to take the asylum. Can you help me with this? If not, I can't understand what you are doing here. So finally, I saw him for 1 year and something, because actually what he was in need, he has a need for safety and for have a stable environment and to have a stable person, a supportive person with him. But this is not only his case. It's a lot of people are isolated in Greece. A lot of people are in a single room just waiting and killing their time. And I'm always thinking about the way that torture affects people's life, and because many people have shared that what was very, very difficult during the torture wasn't the pain, wasn't the beatings, wasn't all these terrible things, was the fact that they were waiting without having any control and without knowing what will happen after 5 minutes. So I'm thinking that they were waiting, and now they are still waiting, and they are still out of control because they continue to be in a limbo situation for a long, long time. So the second case is more related to legal context. As in Spain, we have also a very complex way of for somebody when he's coming and he claims for asylum. And actually, this case describes how stressful and how traumatizing is sometimes all this process for the people. I had the chance to be present in some interviews, accompanying some beneficiaries, and I could see how difficult it was for them to talk about the past and to disclose and to share all these things. And the third case is more cultural related. It's a case of a woman who who was referred due to symptoms of PTSD and due to the fact that she had a lot of nightmares and extreme nightmares. And according to her belief system, these nightmares were attributed to the fact that her family did something to her, and that it's more related to magic. And the psychologist who was working with her tried to make a conversation with her that these symptoms are attributed to your past. And I think that at the end, both of them find a way to communicate without rejecting the point of each other, because she actually managed to accept also a different point of view without leaving her own way of attributing and understanding the trauma. So I think that the main conclusion is that there is nothing post in PTSD, that it's ongoing and it doesn't stop. And until now in Greece, we didn't start to speak about integration. So this is another huge part that we will discuss in the future. And that there is a need, the symptoms to be understood in the context, having in mind all the stressors that people have, and not medicalize torture, not medicalize the symptoms. Of course, this makes our job very challenging because it's very difficult to assess, to diagnose, to identify many times, to attribute, to understand. And what is also very, very interesting is that for the people, to say them that you have PTSD doesn't mean anything. From my clinical experience, I have seen that diagnoses only matter when they need a report and when they need to go through a legal process in order to prove that they are vulnerable, that they should be taken the asylum because they are vulnerable. And also, the term of vulnerability is something that is very, very interesting, because many people become vulnerable after coming and not, they become vulnerable after torture, because waiting and living in overcrowded camps affect them very, very much. And because actually the situation they meet in Greece when they are coming make them feel even more disappointed, because coming to Greece is associated with safety, with security, with recognition of their suffering. So they have a lot of expectation that many of them, for many of them, they should wait. And finally, I want to just share with you that not only for them is very difficult, it's very difficult also for the professionals who work with them. It's very difficult to be psychologists and to work with people who say that we don't have to eat, so we are discussing about basic needs. and you can't offer something practical at that point. So we also, as professionals, we also need support, we also need supervision, and we also need to have good discussion like hopefully we will have after. Thank you very much.
Thank you very much, Christina. Any quick questions? Or we'll leave them till later? One question? Yes, please. The mic, please.
My name is Pau. 25 years ago, Greece was receiving a very big number of refugees from neighboring Albania. Have there been made any comparison with the very huge number at that time and the experience and trauma in other refugee-related issues like integration to the big number of refugees who especially have arrived either by sea or from Turkey in the last 8 or 10 years?
To my knowledge, there aren't research that compare the two different periods of time in Greece. I can share my personal experience. I'm not from Albania, but I'm from Soviet Union. So there are a lot of people who immigrate in Greece 20 years before from these countries. At that time, Greek society wasn't really ready to accept people and to offer culturally appropriate intervention about mental health. And at this point, many Albanian people went back to Albania also. And this is because of the financial crisis. So we have a totally different population now. And but I'm very happy that you ask about this, because although there are different reasons that people came from Albania and people are coming from Syria, the way that the society try to integrate the people, it's quite the same. There is lack of interpreters, there is lack of culturally appropriate intervention, and there is a lot of space to learn. This is something that it's a little bit changed now in Greece, that more and more professionals are more sensitive to all these aspects and want to know more. I don't know if I answered to your question.
I hope this about professionals increasing knowledge and awareness is not only a Greek thing, but also goes for the rest of the world. And I think your presence here at least is an indication that we are interested, all of us, in listening to each other. So I think I'll pass on the floor to Carina Heke from Germany, from Zentrum Überleben in Berlin. Carina also is a clinical psychologist and is currently pursuing her PhD. She has published research on prolonged grief disorder in post-conflict societies and on refugee health. And she works now as a research assistant. She also has experience from Colombia in a project about reconciliation and justice, and has extensive experience in conducting international research projects. The floor is yours, Carina.
Thank you very much for the invitation and the introduction. And I'm very happy to briefly present the work that we are doing at the center. I will just introduce the center itself and the work we're doing there in general, and then I will talk some more about the acute short-term treatment program that we have developed for asylum seekers who are newly arrived. So the center was founded in 1992 as Berlin Center for Torture Victims. Maybe this is the name that is more familiar, but we changed it in 2016 to Center Überleben, which translates to survive, to give a bit recognition to the various offers that we actually have, because we don't only therapeutically work with asylum seekers and refugees, but we also provide legal advice, we document human rights violations, and we also provide qualification and vocational courses. So I brought you a slide with all the different departments that I've developed in the meantime. We had 25 years of anniversary last year, so we only, in 1992, we only had the outpatient clinic for victims of human rights violations and torture. But now we have several departments, but the departments that specifically focus on therapy are the outpatient clinic for adults, but we also have an outpatient clinic for youths and children and youths. And we also have a day clinic for more severely traumatized refugees and asylum seekers. And we also have a housing community for female migrants. I will now talk about how do the people actually come to the center itself. It is usually by word of mouth that the people hear about the center. So when the people that are looking for asylum are coming to Germany, they are registered very quickly. They can claim asylum, and they are immediately referred to shelters, to refugee shelters, and they also receive a monthly payment. I was actually surprised to, and I think we will also discuss this in more detail later, to hear about the difference and these differences between the European countries, how this works. So refugees live in the asylum and in the shelters, and they hear about the Center Überleben usually through the shelters themselves when they need support, or through their lawyers, through other social workers, or through medical doctors. So there are different ways. They can call us within a weekly telephone consultation hour. And usually a lot of people call us, but if the person is likely to fulfill our intake criteria, they are persons who have experienced human rights violations and who are likely to have a trauma reactive disorder, we offer them an initial interview. And when we know that the patient of interest is a minor of age, then we directly refer this person, of course, to the outpatient clinic for children and youths. But for the others, we have this initial interview that you can see right there. We sometimes see very severely traumatized cases where people are not really able to deal with their daily life. And in these cases, we directly refer these persons to the day clinic. This will not be the topic today, but we have this day clinic that offers therapeutic support and other offers daily from 9 to 5 o'clock. And we have 14 patients at the same time, and they usually stay with us for 6 months. But today we will talk a bit more about the outpatient clinic itself. We work with a stepped care approach, which means that we try to offer the support in response to the specific needs the patient has. So usually the higher you get, the more specific the offer gets. But we really try to offer psychotherapy, for example, also only for those people who are really in need of psychotherapy. So we have to do a proper diagnosis at the beginning. Okay. Okay, sorry. So, the program that we had, or that we still have at the outpatient clinic, offers usually weekly sessions of psychotherapy, medical support, and social work. And until about 2013, we usually had patients who had stayed with us for a longer period of time and who had already been in Germany for usually already a couple of months, although they were still asylum seekers, so they were still in the process of claiming asylum. They had severe trauma reactive disorders. But from 2013 on, we realized that the needs had changed. So we saw more patients that had only recently come to Germany and who did not really suffer from chronic PTSD or chronic depression. So we talked a lot about this, and we decided that we needed a program that was adapted to the needs of these newly arrived refugees. So we developed a program that offered rapid and multidisciplinary support for newly arrived people. And this support program not only focused on psychotherapy, but also on social work, for example, because many people still were in the asylum process or needed assistance in finding, for example, a flat in Berlin. And we thought that 6 months could also be enough, maybe, in order to avoid a chronification of the problems the people were facing. I would say the typical patient profile of those we saw during the time, 2013, especially 2015, would be male family fathers, mainly from countries, actually really mainly from Syria, between maybe 35 to 45, more or less 30 to 45. Many of these family fathers had left their families in Jordan in refugee camps or in Syria directly, and they had come alone to Germany because they wanted to make sure they had asylum, and then they wanted to quickly get their family by plane so they would not have to suffer the flight. These men had usually not only suffered trauma in their home country, bombings or imprisonments, torture, but also traumas, Pau actually talked about it, during their flight. So many of them had been incarcerated, for example, in Libya or in other countries. They additionally were faced with problems in their passage through the Mediterranean, so many of them had seen people die. Even when they set foot on European European countries, in Italy or other countries, several of them reported beatings and other human rights violations that they had experienced by police officials. And then they would come to Germany, claim asylum, and this would either take a long time while their family was still endangered in Syria, every day, of course, or they would undergo the Dublin procedure, so they would receive a letter that said, okay, you have to go back to Italy, or you have to go back somewhere else. That was the typical profile of patients that we saw during the time. The symptoms that many of them had were massive feelings of guilt because they had left their families at home. Also nightmares, flashbacks. Very often they had problems with concentration, could not sleep. And it was also sometimes difficult to have the sessions with them because they had they had not slept enough, they were not drinking enough, they had headaches all the time. so they had really difficulties in concentrating. Okay. I will just briefly present some of the more quantitative results that we gathered and that will also be published now within the special issue. So we altogether have data from 44 patients from pre to post treatment. So after the initial interview, they would undergo a diagnosis or diagnostics with screening measures in an interview situation, and as you can see, about 80% of the people of the patients here were male, about 30 years on average, and they mainly came from Syria, Afghanistan, and Iraq. You can see that within the 6 months, you can see that within the 6 months we had a decrease of the PTSD symptoms and the depression symptoms with large effect sizes, and also anxiety. You can see it here, the dark blue line with the middle effect size. The red line, however, also shows what the cutoff point is. So many of the people, many of the patients we had were still scoring above the cutoff for PTSD or depression, even after 6 months and after discharge. But this is also unsurprising because more than half of the patients that are presented here were still in the asylum procedure, were still not reunited with their families. But I think it is actually really promising to see that even in these circumstances, we could actually achieve something together. The study, of course, has several limitations. We have no control group. We can discuss this a bit later, but this is what I want to present you as a first round. Thank you.
Thank you very much, Karina. Any quick questions to the content of Karina's presentation? Otherwise, I suggest that we jump up to Denmark for the last presentation, and that will leave us some time in the end also to have a discussion, to have further questions. I want to pass on the floor to Sabrina. Sabrina Friis-Jørgensen, who is a clinical psychologist also. For those of you who are not familiar with the Danish healthcare system, I just want to briefly mention that there's some specialized clinics around the country, a few highly specialized clinics who take care of the most severely ill patients, but also a number of specialized treatment centers. And Sabrina is from the specialized treatment center called IRCT Jutland, also a psychologist, just like Christina and Karina. And Sabrina will talk about how to predict treatment outcome, or whether treatment outcome can be predicted among traumatized refugees. Please, Sabrina.
Okay. So I'm not really going to talk so much about that. I'm going to tell a little bit about the place I work and do a little brief overview of how the treatment works, the treatment courses. Yeah. So, as you said, I'm from the IRCT Jutland, which is an unpolitical humanitarian organization treating victims. Yeah, sorry. Okay, so we're treating torture survivors and other traumatized refugees. We're not a huge treatment center, but we do have around 180 to 200 patients a year. In 2017, we had 250 referrals, and the majority of newly referred patients are from Syria. So, I want to try to describe what happens from when the patients walk into the IRCT for the first time to when they leave from the last session. And I've tried to do a little model showing this. And I want to start by saying that we do not have the resources necessary to provide the treatment we would like to. So this is not a model showing the best possible treatment. It's a model showing the treatment we can offer with the resources we have. Yeah. So the first thing that happens is that the patients are referred from the GP. And then they're invited to a multidisciplinary assessment procedure. First, they see the psychologist who examine if they are fulfilling the inclusion criteria, which is having PTSD, having experienced a traumatic event in another country than Denmark. And then they examine symptoms of PTSD, depression, anxiety, and so on. And if the patient do meet the inclusion criteria, they are seen by a social worker and a physiotherapist the following week, who assesses the need for physical and social treatment. And during this procedure, they are also answering different questionnaires, measuring symptoms of PTSD, complex PTSD, anxiety, depression, pain levels, pain interference, disability. I tried to show that with the green boxes, and you can see they're doing that again at the end of treatment and at 9 months follow-up. So in this assessment procedure, what we're trying to do is figure out what diagnosis they have, and identify the biopsychosocial resources, the needs, the possibility to go into treatment, and so on. Following that, the visitation committee allocates patients to our different treatment programs. This committee, in this committee, there's a psychiatrist who looks at again, the diagnosis, the need for medication, and then there's two treatment directors, a psychologist and a social worker, and a secretary. So they design the treatment programs, including the number of sessions for each profession. Yeah, so patients are divided into 3 groups. Those with the high resources, they're not so high, but it's high for this group of patients. The medium resources and low resources. And patients with high resources, you can see that's in the top, are offered trauma-focused treatment such as narrative exposure therapy, prolonged exposure, and it's primarily a psychologist. They see 10 sessions of 90 minutes. Sometimes it's followed by sessions with a social worker and a physiotherapist, where they can get 8 sessions of 45 minutes. Yeah. I might also just have to tell the red boxes. We're doing a meeting before the patient starts, planning the treatment, making multidisciplinary goals for the treatment, to make sure we are all working in the same directions. And the yellow boxes is when in the plan, in the phase-based treatments, we meet again in the team to make sure does the treatment go the right way? Do we need to revisit the goals of the treatment and so on? Yeah. In the medium resource group, there's a lot of treatment constellations depending on the patient's needs. It's a big group. Some are offered only psychologist sessions. Some are offered psychologists and social workers and physiotherapy at the same time. And then some are offered group sessions. It's 6 group sessions of 90 minutes where we do psychoeducation. It's not treatment. followed by 5 sessions with a psychologist, and then at the end they can see a social worker and a physiotherapy if they need it. Yeah, and then there's some who sees the psychologist, and afterwards the social worker and the physiotherapist, or the other way around, depending on what kind of issues is the most, yeah. And then we have the low resource group. That's the patients who need help just obtaining an acceptable existence. So the treatment is primarily done by physiotherapists and social workers. And if needed, they can see a psychologist, but only 3 times or 45 minutes. And the psychologist primarily describes them, trying to give them something they can use to strengthening their health network. And it might look as if the patients are receiving a lot of therapy here, but the longest treatment course is 36 hours. And that's the one where you receive group therapy, and it's including the assessment procedure and everything, so it's not a lot. Yeah, and as I told you earlier, at the end of treatment, they're going through the screening procedure again, and again at 9 months follow-up. Yeah, so that was a very brief overview. And then, as you said about the predictors of disability, of treatment outcome, we do allocate patients to different treatment programs based on their functioning or disability. But we thought about it, and we couldn't find any studies who investigated if disability was actually the best predictor of treatment outcome, if there was a reason for even looking at this at the beginning and allocating patients based on this. And we found that overall the level of disability was very, very high, but it couldn't predict treatment outcome, and treatment outcome was symptoms of changes in symptoms of PTSD, anxiety, and depression. Disability in the domain of getting along with other people could predict symptoms of PTSD, where if you were more disabled in that area, you had worse treatment outcome. And in accordance with this, we also found that those living with a partner had worse treatment outcome, which was a little bit surprising, because most studies find that social support is a supportive factor, but it didn't seem that way in our group of patients, which also stresses the need for including the family of the patient, or especially the partner of the patient, which we're trying to focus more on now. Yeah, I think that was it for me.
Thank you very much also to you, Sabrina. Time has now come for all of us to become engaged in this, because the entertainment from this part of the room has now ended. But before we proceed to the questions, I just want to make a short break for an advertisement. So here comes a break. And the advertisement is that you need to look into the upcoming edition of Torture Journal. That's why we're here. We're here to celebrate that there's another edition coming out very soon, I think by the end of the week. Is that true, Nicola? We hope. Very soon. And this has a special section on exactly the problems that we are discussing today. So whichever reply you don't get now, today, you may seek it in the upcoming edition of Torture Journal. And to finalize the break, I just want to briefly mention that this edition has been financed by the Danish Ministry of Research. End of advertisement. You won't get a jingle, but you'll now get a chance to talk. Any questions from the audience? I think I'll take 2 questions and then I'll let the panel reply. And if you want to address a specific member of the panel, please let us know who.
I would like to ask about what has now and then been mentioned in the literature, that most research group torture survivors, together with other asylum seekers and even migrants who also have PTSD, but that probably the different kinds of severity is very large between the 2 groups. And especially here in Denmark, when we have received in the psychiatric system new packages for treatment, that there's still no distinction between patients with very severe trauma who have suffered from systematic torture and patients who have maybe just few experiences of which have caused a more simple form of PTSD. What are your thoughts on this?
Maybe you can hand the mic to the lady behind you. Thank you.
Thank you for your presentations. My name is Louise. I'm also a clinical psychologist. I'd like to ask you, Sabrina, what were your thoughts about that? You said it's actually got worse if you had a partner. Did I get you right? Yeah, the outcome from the treatment. And I would like to hear your hypothesis or whatever you've been thinking about that, because like you just said, that's a quite surprising result. And also for you, Christina, it would be great if you could elaborate more on how you see this contextual way of understanding the, well, you had an introduction about the context of where the PTSD or the critical incidents takes place and how that affects. It would be great to hear more about that. Thanks.
Thank you very much. A bit to start with, something about distinction between severe and mild PTSD, something about why it's dangerous to have a partner. I'll tell my husband. And something about the contextual factors. Anybody in the panel who would like to start?
Now I will use the mic. Okay. So thank you for this question. You're definitely right. We don't have a proper distinction between torture survivors and general migrants in our short-term program. We do in the literature see that the experience of torture is associated with much more severe PTSD cases and other problems. I'm not really sure if I mentioned this correctly, but I will do this right now. So we still have, apart from the short-term therapy program, a long-term therapy program. And it is actually very often that people or patients who experience torture are transferred here, for example, after going through the acute short-term treatment program in the long-term program. And what they also do receive is a more thorough documentation, for example, in the scope of the Istanbul Protocol, of the scars, for example, but we don't differentiate in the therapy.
Sabrina, do you want to elaborate a bit on why it's dangerous to have a partner?
Sure. We think that in other populations, you think that living with a partner, then you have social support. And from our experience at the clinic, it doesn't have to be social support to have a partner. Often the partner is traumatized as well. And they are kind of getting each other. down. So maybe to have someone there who isn't a support is worse than not having anyone. We just ran some analysis where we found that being single wasn't a risk factor, but being divorced was in regards to predicting disability, not PTSD and those things, but in regards to disability, which also implies that having those issues at home that can lead to a divorce is a risk factor. So it's worse than just being single, never having married anyone. Disability in different areas of life, cognition, mobility, all of those things you see in Buddha's, the measurement.
Anybody else from the panel who wants to add anything to these topics that have been brought up? Pau, you have been writing...
Yeah, just to make a reflection, yeah, you write a lot, but we have... we have in our organization, we supervise a special resource for migrant people with severe mental disorder, and we mean by that psychotic symptoms, but post-traumatic psychotic symptoms, yeah, and also severe dissociative disorders, and we are a reference point for all Spain, and there is always empty places in the. I mean, it's 12. We have 12, and why? Because most people doesn't want to go to a mental health resource because of the stigma of mental health. So it's very difficult to combine the victim of the survivor of torture to go to a specialized resource. And in addition, you have a very short time for working with the survivor. If you saw my slide, you just have 6 to 9 months to work, which is the necessary time just to be aware of the need of having treatment. So you probably need 2-3 years to work with severe trauma. So it's very difficult to join the availability with the perceived need of the survivor and trying to, overcome the stigma to finally get someone into treatment. So I think the system is not thought to deal with severe trauma. And probably most people with severe trauma are simply, in this hidden population I told you. It's people that they are undetected, or they are, at home or whatever. That's one reflection. The other, you said that having a partner is a risk factor. That's what you said? No.
That's what Sabrina said.
Oh, okay. That's not what the literature says. What the literature says is the opposite, is that one of the problems we have in this refugee crisis, I agree with Mary, that the word crisis, it's a bit ironical, is the dispersion of families. It's members of the same family are sent to different countries, and reunification is very, very difficult, very difficult. We have many cases of families that, have a brother in Germany, another and it's very difficult. And this is a risk factor. I mean, for many people that you cannot be with your family, it's really, because this is your natural support for dealing with this kind of problems. Yeah.
Christina, do you want to add something about the contextual factors?
By saying the contextual way of see the trauma, I wanted to say that it's very, very important to not to think as a clinician that all the symptoms are related to the torture or to the previous trauma, and neglect all the other aspects, because in this way we neglect the complexity of the person also. Many symptoms can be attributed to the past, but the fact that the present is also very challenging, we we cannot forget about this, because otherwise it's like pathologizing the trauma and the response that people have to the torture, and it's like making that the problem is individual, but the problem is not individual, it is expressed in a society. And the way that we accepting people and we treat people also affect their mental health condition.
I think this was a reminder to everybody that torture and migration problems, refugee problems, is not individual problems. And the reactions people have are normal reactions to abnormal situations. I think if you allow us, Nicola, that we can take a second round of questions. We're approaching 6 o'clock, but there will be time for a couple of more questions. And I have seen already 2 hands, one from Hans and one from Tue. Was that you again? Okay.
Thank you very much for all the presentation. My name is Hans Petersen. I've been working with many of you in the past. I would like to ask Pau about, you have a rather structured program involving, say, psychological, medical, and legal aspects of the situation of the asylum seekers or migrants, and say the context for them is one of the very important factors of the context. That's their legal status. So I would like to ask you about the outcome of all your work, the results, and if you can possibly see a interaction between your, say, legal advices or endeavors and the psychological health of the person you're working with. Thank you.
Although that you have different approaches to the rehabilitation work, I think that, of course, one thing you have in common is that you all are representing European centers. And I noticed that some of you characterize yourself as unpolitical. But I would try to raise the question. There seems to be a tendency of a wish to solve the refugee crisis or the refugee question at a European level. On the other hand, you at the moment have a lot of different national answers or lack of answers. But have you any good idea to set up a sort of European, maybe not a convention, but it may, and maybe the real way is not inside the European Union, but it could be in the Council of Europe, to especially to put focus on victims of torture, and not, as there's a very bad tendency in the first question put up there, to broaden it out on migrants and refugees, instead of especially putting focus on torture victims as a reflection of the UN Convention Against Torture.
And we have one last question, and I'll rush with the mic. Thank you.
Thank you all very much for your presentations. My question's for Christina, but also open to the rest of the panel. And I'm wondering, to what extent are strategies for the rehabilitation of victims of torture affected by the continued precariousness of their situations? Because obviously if safety and a sure future is not being provided, how do you treat these people effectively? A second very short question, which relates less to strategies, but just a point of clarification with Pau. He talked about Melilla and that boy who came across the fence being sent back without being allowed to lodge an asylum claim. I'm just wondering if you could clarify if that's across the board in Melilla and Ceuta, perhaps as well in Morocco, whether that's always the case. Are they ever allowed to lodge asylum claims once they reach Spanish territory? Thank you.
Pau, the question was whether this was a particular case with the young boy who was not allowed to file a case, or whether this is something that's frequently seen. And maybe you can actually answer that first, and then we move on to the broader questions about a European Convention, about how the legal status or the legal outcomes and the psychological outcomes are interlinked. And finally, what do we do with the precarious situation that people find themselves in, not only in terms of their health or migrant status, but in terms of coming to a new country, not having even money to survive in that country, and so on. The floor is yours, Pau, for the first question.
Okay. When we do strategic litigation, we try to be clear that we will probably lose the case. And what we try to do is that the process is healing for the people that we are working with. That's the idea. It's a long process. It will take 2, 3, 4 years. And we try to make it part of the reparation process. But it's quite difficult. You know, and Benito knows, the bigger case we tried to litigate was the Tarajal case. It's a case in Melilla where 14 people were killed by the Spanish police. When they were crossing, the police shot them in the sea, and 40 persons were killed. And it's perfectly documented. There is a video recording of what happened there. There are the expert assessment of the bodies, and in spite of that, the case was closed. It was closed. It was reopened and finally closed. You know, it's very difficult when you litigate against the police of your own country. I mean, you have to know we have litigated cases in detention centers, and of course the case I showed there, it's not an isolated case. It's quite often that people is returned on the border without being allowed to ask for asylum. I mean, they are sent back to Morocco, where they are heavily beaten by the Moroccan police. This is a kind of agreement between the Moroccan and the Spanish police, and people is sent back just for that. We have now 3 cases admitted in the European Court, 3 cases, but this is just a very small part of all the many, many cases that have been pushed back without being given the possibility of asking for asylum. So, we are also litigating in Mexico with cases from the Mexico-Guatemalan border, and there the problem is that they have forensic expert reports done by the police, by the Mexican police, where apparently they document using the Istanbul Protocol that there wasn't torture, and we try to make a counter-report showing that the report done by the police it's unacceptable from a technical point of view, and it's not an independent report, and then trying to, you know, do a good report trying to support the survivor. And again, we have now 3 open cases. We don't have big expectations. But I think it's important to know that, and in spite of that, trying and trying, because from time to time you have, you know, a positive result, and this is worth for all the other. But yeah, we have a lot of success for asylum claims, not big success for litigation against national police. That's it. And then the question. Oh, he went. The question on migrants, refugees. I have the feeling, I don't know, that we work with a small group of privileged people that are, you know, those officially qualified as, you know, asylum seekers and who have the red card. And in Madrid, we have a lot of people who are homeless, who have very severe trauma symptoms. I don't know if this is because they were tortured, or this is because they see too many people dying in the way to Europe, and this is my biggest concern, because for many of them there will never be treatment, and when they have treatment is because, you know, they are violent, dangerous, or whatever. They are admitted to a hospital, and this means being tied, being secluded, having neuroleptics, and, you know, having all the power the psychiatry used against them. So if you are fortunate and you are in this small group of people that receive treatment, then it's fine for you. Fine in the short period of time that you will receive help, but not for the others. So I'm one of those that think that having the criteria of being a torture survivor as a kind of cut-off point is unfair for most of the people, because of course we must put survival of torture as a priority, but there are so many ways of suffering in the way that doesn't fit in the UNCAT definition of torture that we cannot close our eyes to that. So I think that, of course, it's a priority, and of course we should keep the focus on the refugee status and on, but also we should be open to other realities. And every time more there is people that hasn't been tortured in their country of origin, but they deserve also being part of our focus of attention. How to do that? It's very difficult because the system is not thought for that, and that's a challenge. But to me, it's an ethical duty to open also our work to, and for instance, we document cases which probably they don't fit in the definition of torture, but they use the Istanbul Protocol, and we try to document the suffering in the way to Europe, and also try to get humanitarian protection for them.
Thank you, Pau. Anybody else from the panel wants to add something to what has already been said?
I will briefly add, because the other questions, I think, are regarded towards you. So I just wanted to say, I mean, there is a European guideline for the protection of particularly vulnerable groups, including persons who have suffered torture, LGBT people, disabled people. So we already have a guideline, but it's just very poorly implemented. And I think this is the problem. You were asking for European solution. So there is an approach and an idea where we want to get to, but up to now, the countries don't really implement what they actually should be doing. We're having a project at the center also, which aims at developing a screening instrument for these particular vulnerabilities, so that in the case that, for example, social workers or other people realize that there is a vulnerability, that this person will be directed to the specialized institutions that can then perform diagnostics or whatever it is. But it is a long way, and there is at the moment no political will to really improve the situation.
Thank you. Christina, there were some questions directed to you.
So, at the first step, the way that we are trying to address the needs and to be effective is that we are a multidisciplinary team, so there are a lot of professionals that try to help the person in the same time, and we try to refer the person to the appropriate services in order to cover the basic needs and the accommodation. And sometimes this is not enough, and we must to advocate for these people in order to explain and to say how much important are the environmental factors for their mental health, because it's not obvious, especially for people who are not from mental health professions, and sometimes you must just convince that it's very important for somebody who is victim of torture and also psychotic to have a proper accommodation, because otherwise it's not possible for this person to take the meds. So we try to advocate a lot for this, and sometimes this is also not enough. And after we just try to be there for the person and to pass through this process with him, because it's better than to be alone.
Thank you very much. Sabrina, do you have anything to add to what has already been said? Okay, thank you. I think even though we may not have gotten answers to everything, that we also need this day to come to an end. So once again, I don't have a torture jingle, but don't forget to read that magazine when it comes out. And also, thank you very much, all of you, for coming. It has been a pleasure. And I hope that you will take the opportunity to not only speak with those that you already know when you leave the room, but maybe approach someone else and say, hey, what's your field of work? You might meet someone who does something interesting that you could take advantage of. To finalize, I want to share with you that this event has only been possible because a lot of work has been done by three particular people in IRCT. So my final words will go towards Nicola, to Cesare, and to Jeanette. Thank you very much for organizing this, and thank you all for coming.